Lovely. So I'm going to do a CPD today on the new classification of muscle injuries. So this is a paper. It actually was first published in 2014, and then it got rejected. So it went away for 2 years, and now it's come back out again about a year ago. And it was done by British Athletics, and they employed some people to do it. And what they've done is they've looked at how we classify muscle injuries now. I've said it's a load of rubbish, and have then come back with a new, relatively similar plan. So I'll go through kind of why they've kind of said to the old one that's no good, and why we should begin to classify it in different ways. Now the paper is about 3 pages long of how you classify a muscle injury, so I've broken it down into kind of distinct points. If you want to have a bit more of a read, I can ping that across on an email to have a look through. So I just went through causes of muscle injury. So you might get acute based ones, so sports based, running, throwing, jumping, anything like that. Lifting, so kind of your gym based ones, excess weight, bad technique, slipping out in the gym, slip, poor flexibility, muscle length, overstretching, and then you've got kind of links back into your sports ones like your acceleration, deceleration, and impact ones. And this is really kind of beginning to how they break it down into the new standards. And then you can get kind of chronic muscle injuries, so sports-based, so repetitive-based sports, tennis, cricket, baseball. I suffer a lot from these by playing a lot of cricket. And then kind of poor posture, work conditions, and people with New Year's resolutions who come January say, I'm going to get in the gym, they've got horrific posture, they go and think, oh, I can pick up 40 kg, and then bang, the muscle goes straight away, and it's because of that long-term poor posture. So muscles, what we might see, having a look at the lower limb. This was mainly a sports-based study that I found, but it's looking at kind of the common ones that we see through a physio practice. Football and rugby, 92% of muscle injuries are lower limb, which is probably quite self-explanatory. Hamstrings were 37%, adductors 23%, quads 19%, and calf 13%. And 96% of these injuries are non-contact, so acceleration, deceleration injuries rather than a direct blow. That tends to be more your ligament-based tears. Upper limb, no data, but generally rotator cuff tears, obliques. I don't know why that still says hamstrings, because obviously that is the lower limb. Now, so this is what they're trying to get rid of. Some of it I agree with, some of it I don't quite agree with. Their big thing that they're trying to get rid of is the use of the word strain. And they say we shouldn't diagnose anything as a strain. And they kind of go into what is the true definition of a strain. I think I've strained a muscle in my leg, okay, in my hamstring. Which muscle have you strained? What is a strain? Is it a small tear? Is it that you've just irritated some of the muscle? Is it a tendinopathy? And they said that no one really could put a true definition on the word strain. And they looked at when athletes were diagnosed with a strain of a muscle, their treatment afterwards, and how quickly they went back to sport, how often they re-injured. So in Aussie Rules football, it was an Australian study, 30% of people diagnosed with a strain were back on the treatment table within 6 weeks' time because it was misdiagnosed, 23% in rugby and 16% in football. So that's quite a heavy rate of people coming back in who were diagnosed with a strain, less than 6 weeks later were back in with exactly the same injury because it had been misdiagnosed and they'd actually had a grade 1, a grade 2 kind of tear underneath it.
So we should be referring to, because I call them muscle strains all the time.
Yeah.
And I just think of it as it's not quite a grade 1, so it's you've just pulled the muscle.
And that's what they wanted to break down into it, because they said a grade 1 is a tear of a muscle, but they said they were saying that people tend to use the word strain, but they were saying that strain was completely inaccurate, because you could be just slightly below a grade 1 and it could be called a strain, and you could have literally just slightly aggravated your hamstring and you'd also diagnose it as a strain. And those were the injuries they were looking at, where actually it was almost actually a grade 1 tear being called a strain. They were put back to sport in 2 weeks, and then the problem was there again. So they're saying that they ideally wouldn't have us using the word strain. Now I think that's great for people who speak in physio talk, but I think when you're speaking to a patient and you turn around and say you've got a 2A minor muscle tear, they can go, well, I don't have a clue what that is. So I think patient speak, strain, can still be quite important, but I think in our mind it's key to start not using it. So they got 15 experts. This was a mixture of physios and club doctors from UEFA and the IOC, and they all agreed straight away to not use strain anymore. And then they wanted to quiz this a little bit further and said, if you were to diagnose a strain, what would you diagnose that as? So obviously the main majority said 68% is a structural injury, so looking at kind of lumbar functions and saying that a strain comes from a tightness somewhere that causes that. 16% consider it a functional muscle injury, so like your normal tear. So they're the ones who are looking at it more being like a grade 1. And these are the guys that are looking at it being one of those things that kind of clears up in a couple of days. And 16% of them turn around and say, actually, I don't know what I would diagnose as a strain, which for probably some of the highest level physios and club doctors in the world is quite a big amount for them to go, oh, I don't really know what it is. And again, they said what they want to try and do is, as much as they base on the grade 1, 2 and 3, they want to try and take that away, because they were saying between a grade 1 and a 2 there is a massive bit in between. Between a grade 2 and a 3 even more, there is a huge amount. So how can you diagnose a grade 2, upper, lower? And that's what they said. There were so many grey areas amongst it, and they were finding that so many people getting...
That's why they split to A, B.
Yeah. So this is what they've brought it onto. Now I've kind of compressed this down into quite
2014.
Yes. Kind of compress this down into quite a short way. They really break this down further with pictures. So they've said grade 1A, so this is almost to replace strain now. Grade 1A is a fatigue-induced muscle disorder. So, and they said how you look for it as an inpatient is increased muscle tone. So you often see these quite acute, a few days afterwards, a bit of increased muscle tone, aching muscle with continued activity, and a bit of pain on rest after an activity. So can often be a little bit confused with a kind of a tendinopathy type pain. But this, I think, is what they're trying to bring in instead of strain. A grade 1A, one of those ones that you see a couple of days after injury.
A grade 1A tear.
A grade 1A tear, but it's actually not a tear. So it's a grade 1A muscle injury. So they're saying that the word tear, again, and strain shouldn't go. We should use muscle injury rather than tear.
Lovely.
And the patient would report dull, diffuse, tolerable pain with maybe slightly increased tone. So they might say, oh, I can feel my hamstring slightly today. It feels a bit tougher in here. And the patient will often describe it to you as, I feel like my hamstring is tight when I go to run. When I used to work with the hockey clubs, I saw this all the time. At the end of the game, my muscle feels tight. I think I've strained my hamstring. No, I don't think you have. I think this is what you've got. Grade 1B, they diagnosed that as the DOMS. So when people come in with delayed onset of muscle soreness, they said that this was 1B. So when the patient's engaged in something that they weren't used to, usually acceleration or deceleration injuries, so often people who had a summer break from a sport, went back to a sport in their first few weeks of training, and they were suffering with some ache afterwards, going back into what I was saying before, your New Year's gymmers, when they're going in and then they're really aching for 3-4 days afterwards. And it's kind of an acute inflammatory pain, and this often comes on after hours of activity. So they'll feel great when they're doing it. These guys that go in the gym think, yeah, I can pick up 30 kilos, I haven't done this before, and then they're out of action for 3 days afterwards. And then the patients would diagnose this, or they describe, I feel like I've got a bit of swelling, potentially. The main thing is that they say it's stiff, and they'll notice that they've got limited range of movement of the adjacent joints, especially when working into isometrics. So they've gone in the gym, they've done lots of squats, kind of their glutes and hamstrings are going, and then they're really struggling to move their hips and their knees for the rest of the day. And you see them kind of walking up the corridor like this because they're not doing what they used to. Now, this is where it gets into probably a bit more what we will see and what people will generally come to physio for. Mm-hmm. So grade 2A, a spine-related muscle disorder. So this is so the grade 2 bit really bridges the gap in between kind of a strain and a tear. So where we're not saying that there's an actual tear in the fibres, this is where it begins to come in. So grade 2A is when there's an increase of muscle tone due to a structural lumbar disorder. So kind of pelvic rotation, difficulty with kind of a scoliosis or reduced lordosis, and you've got increased muscle tone into kind of your hamstrings, your spinal muscles. And they're just focusing on a 2A being for the muscles surrounded by the spine. So upper limb wise, you wouldn't diagnose a 2A, but you would diagnose kind of a lower problem. So aching muscles, worse with increased activity, although no pain at rest. So these are the classic ones that you'll see with your kind of builders, manual workers, who'll get a lot of pain as they're lifting up because they might have chronically tight hamstrings and that affects onto their back. So when they go to pick up things at like bricks at work, that's when they really struggle getting their pain through. And again, a patient would describe it as that they can feel the pain. So you often see it a lot through the QL where they say, oh, kind of, yeah, my pain's really coming through here. and you really get kind of a defensive mechanism on stretching. So say they've got a 2A in their back, they say, yeah, that feels fine, my pain's all to the left, and then they go here and they really resist it. They really don't want to go that way at all. So a grade 2A muscle injury is almost like mechanical back pains, is what they've put it down to. So your muscular back pains. Grade 2B, we probably don't see too much. This is when they're looking down the more the neuro route of injury. So kind of increase in muscle tone due to dysfunctional neuromuscular disorder. So this is when they began to touch on things like spasticity and things. So as I say, in terms of what we see here, we probably wouldn't ever really see a 2B too much. Again, the patient would describe it as kind of an aching cramp pain, and they feel that the muscle's quite kind of firm and tense through the range. Sore on palpation when we have a feel of it, but actually stretching out of that muscle, if they've got kind of increased tone, especially through neuro, when you really kind of get in it and stretch it, they get quite a lot of relief from that. Now, this is where we come into play. So, grade 3A is basically replacing what we probably diagnose now as a grade 1. So a minor partial muscle tear. So at no point here is the whole fibre being torn, the whole muscle being torn. But it's a minor one. And this is where I think it becomes a little bit unstuck, because I think it is a little bit subjective still as to what is a minor partial and a moderate partial tear. I think this is where you can still get a bit of subjectivity in it. Because a tear with a diameter less than the muscle fascia or bundle, for us seeing a patient here would be impossible for us to tell unless you had an ultrasound scan on top of that. Mm-hmm. So I think for us physios working here, this is where the new diagnostic of muscle injuries becomes a little bit unstuck still. Again, I've kind of put into it what we could look for when we're kind of looking into in clinic. So the patient would come in and report a sharp pain at the type of injury, and they often feel a snap or a pop. Commonly seen kind of with your cuffs when people are throwing, they say, or pulling a cord on a lawnmower, they say, oh yeah, I felt my shoulder go, felt a snap, felt a pop, and then they said that the pain was there straight away, and they can really pinpoint that pain. It's localized, it doesn't radiate, and they can say, I felt my shoulder go or felt my hamstring go, and my pain is here, I can feel it in here. And then when we're looking at it, again, the pain will be very localized. When we palpate, we can go on there and really poke it and say, yeah, that is your pain, and they'll go, yeah, that's where I feel it, and that really kind of gets the patient on board. And then if you palpate through the muscle band, through the muscle fibre, the pain will continue going down through that area. And if you stretch that muscle, the patient won't like it. It will be sore. So if they've torn a hamstring, you'll be able to localise the point almost exactly where the tear is, and then if you palpate through the rest of it, they'll be able to say, yeah, I can feel that all the way through, that's sore, that's sore, that's sore. And if you take them into a 90 muscle stretch, they won't be liking that at all, because they'll be able to say, yeah, my pain is here, and they can really localise that type of pain. Moving on to 3B, again, as I say, it's tough because it says, again, a tear with a diameter more than the muscle fascia or bundle. Again, near impossible for us to tell. But again, it's looking at what we'd look for when a patient would come in. So, and this is where you can see the subtle differences in between what they would describe. So they describe it as a stabbing or sharp pain, but they wouldn't necessarily say, I heard a tear or a snap. Which I know seems funny because it's a more severe muscle tear, but because more of it was being torn, they might not definitely feel that slight go. But again, the pain will be localised, and they'll be able to say, this is where my pain is, I can feel it right here. The study showed that the most common grade 3B that they found out of all the research that they did was a cuff tear, and it was often diagnosed with a fall. A patient would say, I fell. Because you fall and you tear your cuff, you don't necessarily feel that immediate twang of a hamstring going. But they said as soon as I fell, I could feel my shoulder here, and it was really quite sharp. And then that pain tends to be stabbing, and it doesn't particularly go away. Again, what we look for when they come into clinic, a really well-defined localised pain. So we'll be able to poke that point and say, this is where your pain is, this is where I think it's torn, this is where it is. And they'll be going, yeah, that's exactly where it is. and we'll be able to almost feel a defect in the muscle, because this tear is a large proportion of the fibres. If you put that muscle under tension and feel it, you should be able to feel that there is a defect in it. One of the more common ones you see, and this is often with a rupture, but you can see it with kind of a grade 3B tear, is when someone does their bicep. You're able to really feel, and you'll often see it as well, where you get that slight lump, and then you'll be able to, as long as you're pretty sure it's not a full rupture, you'll be able to come off onto the tendon and feel that there is a complete defect in that muscle there. And that's probably the nicest one, where you can really see it as well as feel it. Often be a hematoma, so get some bruising, get some swelling around that area, which is the main difference between a grade 3A and 3B. The patient will either have a picture of it, because most people like to take a picture when you've got a bruise, and they'll be able to come in and say, yeah, it was really bruised when it first happened. And that's, I think, the key way of diagnosing in between these two. And again, similar to the last one, if you stretch it, they're not going to like it, and they're not going to like it even more than if it was a tiny one. So if you're beginning to stretch a muscle and they're immediately increasing their muscle tone, trying to resist it, that tells you that it's more of a 3B. Now, grade 4, this is almost going back to what they could call a grade 3. So it's a total muscle tear or avulsion. So that's when the complete muscle diameter between the bone and tendon junction has torn. Again, as I say, not 100% easy for us to tell without imaging, but probably a lot more obvious if there is a complete tear. And a lot easier to diagnose, because the way the patient describes it is in a completely different way as to it was a partial tear. As I say, the pain will be dull. It won't be that sharp pain like you get with a partial tear, but they would feel that tear or snap. They would have felt it go, but there wouldn't necessarily be that sudden, oh, I've got it. It would feel quite dull, and almost, patients often describe it as a bit of almost a numbing type feeling when it goes. And then gradually this develops into a localised pain. And the key here is the disability bit. If you have torn something with kind of a 3 or a 3B, you can carry on going. We often see cuff tears that come in, and actually they've been all right for 6 months, and they say, oh, well, I just can't get that last bit of abduction, or I can't lift my washing up to the side. If you've got a total tear of grade 4, you will be in a bad way. You will have real disability of that joint, that muscle. You won't have any range of movement, and your strength will be completely gone. That's when you're looking, especially with cuff tests, for your lag signs. Those would be the key. What we'd look for, you'd be able to see the defect straight away. There'd be a definite gap in the muscle, so you tension up the muscle and you'd be able to see that gap straight away. Again, similar to what I was saying before, especially with the bicep, if they have ruptured it's like the Popeye. You see it straight away, right in the middle, and then you come off onto the tendon, upper or lower, and there's just absolutely nothing there. You're just pushing on flesh, basically. Hematoma, 100%, and often when you get a grade 4, you can get some really nice hematomas. I think a nice one is when you do your subscrap. You get a lovely, it's almost like a tyres run over you that you get coming down you get a rainbow, comes across the pec, down the bicep. When you kind of get a hamstring tear, it will often kind of come all the way down into the calf. But I think the key bit is, I saw a patient not too long ago. He came in and he'd injured himself the day before. He said, oh, I think I've done something to my hamstring. He said, oh, I felt it go, but I haven't really got in too much pain. He was wearing joggers, and he described it as a kind of a dull pain, a numbing pain. Took his trousers off, and the bruise he had down his leg, he obviously hadn't had a look, was incredible. So the patients may not always know that there's that severe tear, but once you have a look and you see kind of that they don't have their range of movement, it's quite key to see straight away. The muscles either side will often retract, because you've torn it, and they will retract either side. Pain with movement, loss of function, disability, quite obviously, that's what you'll be able to look for. So they'll have loss of range of movement, lack of strength, their gait, if it's a lower limb one, will often be off, their shoulder range will be off, it's clear to see. And then finally, now you don't tend to see too many of these, as I said before, 96% of muscle injuries are non-contact. So this is that 4% that you're probably more going to see if you go out and work at a sports pitch, and kind of your rugby pitches on the side, the guys that run on. And the easiest to diagnose, because the patient will come in and say, I was tackled in rugby and I felt my muscle go. So it's a blunt trauma straight away with a bruise or with swelling. and as I say, the patient will come in and report that. It's pretty easy to tell when it has been a blunt trauma injury. But very, very similar to your kind of grade 4, so a dull pain increases as the bruising gets bigger, and there's an external mechanism that causes the pain, and it's making sure that there is that definitive external mechanism. So someone will come in and say, yeah, I was hit, I was pushed, I was this, rather than it being I think I was running, I think I was doing this, I'm not quite sure. And exactly the same as the last one: swelling, dull, diffuse pain, decreased range of movement. And it says depending on the severity of palpatable pain. I think if you've got a kind of a direct trauma muscle injury, there will be palpatable pain most of the time, unless you're seeing it in that very, very acute stage, pitch side or something like that. I think if they were to come into the clinic, you would be able to palpate the pain. So, how to diagnose a muscle injury, just a summary. So making sure you've got a solid subjective, so looking at kind of how it happened, and this is how you diagnose in between a direct trauma, a grade 4, a grade 3, and then looking at the symptoms that they've got, because that will be the key. As I say, it's looking at how they describe their pain. Have they got a bruise? Have they noticed a bruise? Was the pain there straight away? Were they able to carry on afterwards? Have they noticed their gait changing? Making sure you get that key breakdown is the key way to diagnose in between each of these ones, because actually, as you saw, in between kind of a grade 4 and a direct trauma, the symptoms that you see without even talking to the patient would be quite similar. The grade 3A and 3B, again, quite similar. So I think it's subjective for a muscle injury when using these new guidelines is really key to help you diagnose. Objective to help you diagnose, obviously palpation, so looking at any edema, muscle tone, and as I say, the larger tears, you'll see the defect in the muscle. Bruising, and then looking at your muscle function, so looking at both concentric and eccentric function. That's the key, because if it is a larger tear, their eccentric function will be shot. So if you're looking at kind of your grade 3As, 3Bs, the eccentric function of their muscle will be really poor, and you can especially see that in the hamstring when you're getting them to just actively extend it, that it's juddering all the way down, and that's the key way that you can tell. Now the study obviously does go into ultrasound scans and MRIs. They found that the ultrasound scan for a muscle injury was only accurate between 2 and 72 hours post-injury. They said anything past that you couldn't get a clear diagnosis as to how bad the injury was or exactly how many fibres were torn, either because the edema was too big or because a smaller tear had already begun to go into the recovery process and you couldn't exactly tell how well it was. And an MRI, I think this is looking down your really kind of elite sportsman route. If they have had a direct trauma or a grade 4 injury, they did recommend an MRI. Obviously, that I think in our clinic we probably wouldn't recommend an MRI. I think we'd rehab it in-house, and then if it wasn't getting better, that's the route we would look down. But as I say, this was done by kind of British Athletics and UEFA, so it was more tailored at elite sportsmen with club physios and pitch side physios. So obviously we had to take it a little bit with a pinch of salt. And then what I've done is I've just gone into how I would rehab a muscle injury, and I'd be looking at a grade 3B, so a moderate partial muscle tear. Now I think people will disagree with this, but personally this is how I do it. And you look at the research online, and this counters all the time. Some people say one thing, some people say another thing. Some people say try not rest it for too long. Some people say trying to load it up straight away, which I know I'm keen to do with shoulders and things like your impingements. So what I generally do, so say we saw them day dots, they came in day 0, day 1. For the first week, I don't get them to do a lot. So rest, ice, elevation, get it up, get it ice straight away. Really try and break down some of that swelling, and just some really gentle active assisted stretching. So if they come in, just getting them, just really doing some gentle stretching for them. So say it's a calf injury, getting them on the bed and just doing some active assisted dorsiflexion, plantar flexion. I'll then get them in potentially 1-2 times that week, and then get them in the week after. Still complete rest from sports, obviously, being that soon after injury. The research tends to show, when you kind of look at the research studies that have looked a lot, it's almost a 50-50 split at this point between ice and heat, what people prefer and what people have found works better. Personally, I use ice. I think ice is much better, but the research didn't really diagnose or differentiate between ice or heat. And this is when they said you need to start bringing in your ultrasounds, your lasers, and then get the patient to start doing some gentle stretching. So just really low range gentle stretching. So days 14 to 21, so 2 to 3 weeks. Again, complete rest, as I said before, no real difference between ice and heat, ultrasound laser. This is when they say you can start to bring in some gentle massage. There was no real research for massaging under 2 weeks worth of muscle injury. It tends to stick away from it, especially your calves and your hamstrings, just because you're at massive risk of causing anything going up, especially with your oldies. And they've torn a calf. I would stay away from that for a good few weeks, potentially even longer than 3 weeks, just because of your risk of causing other problems like DVTs and clots and getting the blood moving further up. Stretch, so continue with your stretching, but go back to kind of a normal stretching, so as if you were trying to stretch out a muscle normally. And this is when you begin to build in a little bit of eccentric muscle control. So say it was a hamstring tear, what I tend to do is get them laid on their front, knee up behind them, and just getting them to really, really slowly control that muscle all the way down, just working it through the eccentric range. But no concentric work, no TheraBand work, keeping it really, really nice and simple, just getting a bit of strength through that range, combining the stretching and the strengthening. Weeks 3 to 5, again, still be resting from sport at this point, ice, heat, ultrasound, laser, massage, high level stretching now, so really getting that muscle, testing it through its complete range now. Really working on your eccentric loading, so not just your eccentric muscle control, again, if it was a calf tear, getting them on the step. And beginning to add in a little bit of TheraBand work as well. So beginning to focus on a little bit of concentric work, but starting them off low TheraBand and then working them through on the weeks. At this point, if the patient was willing to, I'd still be seeing them probably at least once a week, if not twice a week, really helping them through the muscle tear. Especially because these guys are looking to get back to sport, and I think you can facilitate it quite quickly if you help them out. Week 6 to 8. I get them back to very gentle training, so no contact-based stuff. So if they're football, rugby, no contact, just doing some light training like jogging, kicking, things like that. Can stop with the ice and heat regularly, but ice after any training, whether that's loading, training, the light training, any gym work, any concentric loading, they've got to ice it straight away. Same before, ultrasound laser massage, and then you begin to start concentrically loading it. Now, I could have been a bit generous here, kind of 2 weeks of concentric loading might be enough. This is where it becomes a little bit, you've got to go by your patients. Some will recover really quickly, others could end up being, that can end up being more kind of 6 to 10, 6 to 12 weeks. And as I say, kind of going back to what I said before, there is still that bit of subjectiveness in between what is a minor, a moderate, and a grade 4 kind of 3 muscle tear. Because if they're at the greater end of a grade 3 muscle tear, they're obviously going to take a little bit longer to get better. Weeks 8 plus, but as I say, this could be 10 plus, 12 plus. You then got to facilitate their return to sports, and this is going to depend a lot on the sport they do. If it's a non-contact sport, that will happen quite quickly. Someone who might have a direct trauma injury from rugby, that's going to take a lot of time to get them back because you've got to get their muscle to complete strength. Your cricketers, if they've torn their cuff or had a shoulder injury, again, that's going to take a little bit longer because they've got so many muscles and compound exercises that are going to take them to get them back to it. So at this point, you're really loading them up to the high level, so kind of doing a lot of Bosu ball work, gym work, really getting that muscle working through the range, and doing some sport-specific rehab. So there's no point with a cricketer just doing gym work. They need to be doing a lot of overhead work and things like that. Rugby players and sprinters doing some acceleration and deceleration work because that's the things that they need to go back to. And I would still, when they come in to see you, ultrasound, laser, massage, keep on going with those as much as you can and really facilitate them to get back to their sports. Now, obviously, that's what I would do. I don't know if anyone else has any ideas, counters, what they do to get kind of a muscle injury back.
I agree. I will possibly start a bit earlier with eccentric, but again, it all depends on the person, really.
Yeah.
Because this can work for one person, the other person you have to slow down a little bit, and with the other ones, same with, as you said, with the grade 3B. You think it's grade 3B, and might be actually different grade, and you can actually start doing exercise earlier because you can feel that there's no pain, there's no inflammation. We can start earlier. So it's sort of very, very good for generalization. But yes, as you said,
you've got to be patient specific. Yeah, and I think that's the thing where that research paper falls down slightly for us. As I say, it's tailored at pitch side, high-level physio clinics that would scan something straight away and say, this is less than the muscle fibre, it's 100% a grade 3A, this is how we can rehab it. For us, we've got to use our clinical skills a little bit more. So I think from our point of view, that's where the research paper falls down slightly. But in terms of diagnosing a muscle injury, I think it's great. I think it's fantastic when you compare it back to the old way. I still think there is an element of subjectivity here, but I think when you compare it to the old way, it's cut out so many different kind of loopholes that you could find in that one. But yeah, give it a go. Kind of with your patients, try out some different treatment techniques. And actually, when you talk to patients, it's quite a nice way of explaining it with them. Because if you go, it's a grade 2 muscle tear, and they go, "Oh, how bad is that?" And you go, "Oh, well, a grade 2 is it could be this, or it could be this, or it could be this." Whereas this, you can say, "Oh, it's a grade 3B, and this means that this amount is torn." And even as we said, if you're not quite sure, but you can still say, "Actually, I feel it's just slightly more than the muscle bundle." The patients think, "Oh, wow, he really knows what he's talking about. He's kind of delved down quite far here." And they're buy on straight away, because you can then link it back to something like this and say, "We're going to need to get you in quite regularly to get you back to where you want." And the patient just has trust in you straight away. Because as I say, a lot of people with the muscle injuries will be sportsmen, and they want to get back as quickly as possible. But the other thing is, they don't want to take any more time out. If they're going to have 8 weeks out from a sport, they do not want another 8 weeks out. And that's going back into what I said to begin with. Strain was causing people to go back, come back, go back, come back as much as you can.